Hello, everyone. My name is Solomay Tibabu. I'm the host of the Going Digital Behavioral Health Tech Conference, and I'm so excited to have Dr. Omar Manejwala here with us, Chief Medical Officer of DarioHealth. Welcome.
Thank you. Yeah, soulmates, it's great to be with you again.
Today, we're talking about ignoring patient preferences and the voice of the patient in mental health care. Can you tell me from your perspective why that's important?
Yeah, sure, Solomon. And I want to say that it's really great to see you again, and congrats on another, amazing conference. Last year, I said, I think you saw this, I said that it's the best behavioral health conference that I've been to. And based on the lineup, I think 80 speakers this year looks even better. So super excited about that. Yeah. So voice of the patient, voice of the member. For years we've been saying that there's under treatment. That's really true in all demographics. We see folks that are, not getting the care that they need. But there's also mismatched treatment where people who could be managed maybe through coaching or self-guided or other approaches, they're not getting that care. They just end up getting whatever care might be offered in the particular setting that they go to. So, we all know that we have limited provider resources, especially specialists, for example. It's very inefficient. And also, I think it's just wrong. If you're going to deploy a particular type of care to somebody simply because that's what's at the disposal at that location or in that solution, it's sort of like when you're a hammer, everything looks like a nail. And then also, there are many folks who go for one visit to a provider and they never return or they give up. The help doesn't look the way that they expected it to look, or maybe they didn't feel heard, didn't feel, listened to. Maybe they felt that people were making assumptions about what they were experiencing or assumptions about what they were expecting, maybe. So, it's no secret that if initial care, like getting that first visit, is uncommon, then follow through is especially difficult to achieve. So, we look to the voice of the patient. We look to the voice of the people actually receiving the care. We listen to them. We learn from them. We ask them to be our teachers. And then we have a shot at doing this thing the right way. We have a chance to do it the right way. We always say our patients are our best teachers, but then we all go and deploy whatever we think they need. That's arrogant. Not everybody needs CBT. Not everybody wants CBT. Not everybody wants pharmacotherapy. Not everybody wants 12-step based approaches. People differ. And so if we're deploying a provider-driven, let's just say, for example, we're deploying a provider-driven telepsychiatry solution, then all those users are going to get matched with a psychiatrist. If we're deploying a CBT-only app, then everybody's going to get, CBT. And so if you're a telehealth network solution, for example, then that's what everybody's going to get. And that's just, if I can be very direct about it, that's a very ridiculous way to allocate care. And it explains, at least in part, it's not the whole explanation, but explains at least in part, why we're failing in mental health. And so as I go back to your original question, which is, I think, a really great question, why is it important to pay attention? Why is it really important to pay attention to the patient voice here? And patient preferences. Patient preferences matter because for many reasons. But it's both the under and the over utilization of care. It's failure to adequately engage or retain people in care. It's the mismatching of care. It's health equity. Hope we get a chance to talk about health equity today. It's ensuring that the site of care or the specific solution that happens to be offered isn't the thing that's dictating, what people receive. It's putting people back in the driver's seat. It's allowing an opportunity to optimize that care and maybe even use the savings from the efficiencies in that process to drive even more access to appropriate care. So I'd say patient preference, patient voice, that can really help do all of that.
You mentioned something earlier, patients may feel like they aren't being heard. Is it just provider stigma, or are there cultural reasons for that?
Yeah. So that's a great question. Certainly provider stigma plays a role. It plays a huge role. And there's a growing body of research that language matters, that race and ethnicity matter. Many factors are at play in determining the type and quality of care that people receive. And obviously that's a moral imperative for everyone at the conference and everybody they work with. This is a moral imperative for us. We should never have been in a situation, we shouldn't today be in a situation where the type of care or the quality of care that you get is determined by factors, any factors that aren't related to the best intervention for that person. So we know a lot about provider stigma. We know that it exists. We know that it's often unconscious bias, right? So we also know that there's inadequate training. So there's big gaps in training. There's underdosing of treatments. We see that a lot in disenfranchised populations. As a result, we see increased cost. We see decreased engagement, impaired clinical outcomes. But, on the other hand, Salome, I think it's exceedingly naive, if I can say it that way, to focus all the blame on providers when they're already stretched to the max, they're under pressure for clinical and financial outcomes, and they're forced to operate in environments which are perpetuating that problem. So environments where matching care appropriately is disincentivized. What I mean that is if a patient comes to see you, all right, and there's an incentive for you to provide care in that setting, even if other types of care might be as effective or in some cases even more effective and certainly more efficient, that disincentivizes effective matching of care. And so the effort that it takes, the energy it takes as a provider, as someone who's providing care, to triage someone to the optimal care, all that's disincentivized. And the tools to provide optimized care, all those things are missing. And that's why, if you're a telepsychiatry company and people call you up or you get a referral, that person's going to get telepsychiatry. And if you're a cognitive behavioral therapy app and something gets referred to you because your employer covers that or whatever, that's what you're going to get. And that cannot be the most efficient way to allocate resources. So I think it's important to recognize that many people ended up in that site of care or with that company or with that app specifically because of how it was covered. It was in network maybe in some way, or they were referred in that way. So those referral pathways, talk about, the referral pathways, the proprietary kinds of networks, they all create very perverse incentives towards underutilization, overutilization. Let's call it misutilization, where people are not getting the right care for them. In many cases, not getting the care that they would actually want to receive if they had if we were listening, if they had a choice about that. They're just getting what's available. They're just getting what's convenient, and that's wrong. So a better way to do things would be to solve the structural inadequacies so that people could get screening, optimized kind of screening up front, engage the care that they want to receive, care that may be more efficient, for them, care that may not require synchronous visits like we see in telehealth, or maybe it does involve synchronous kinds of visits. It may involve a combination of those things, but most importantly, it's efficient care, it's optimized care, it reflects what that person wants and what that person prefers, and so it's a full continuum. It has to include a full continuum care, ranging from self-managed all the way through provider visits. That can operate in many different environments with different provider networks. Can't be tied down to a specific provider network. It has to be scalable. It has to be configurable. And it has to have a mechanism in place for dynamically adapting in response to what I want. So one day I might want, therapy visits. Another day I might want something else. And that has to be normalized. I can't be shamed or feel like it requires some effort for me to move seamlessly between these different levels of care. And if you don't have that, if you don't have the ability to dynamically move between these things, you can't really blame stigma. I think we have to blame ourselves for not having solved that problem yet.
Super interesting. So last year at the Going Digital conference, you caused a little bit of a controversy, I can say so myself, by saying that engagement is the most important factor in digital behavioral health. Even more important than clinical outcomes, in fact. What role does patient preference play in driving engagement?
Okay. Yeah, that's fair. That's fair. I guess last year I was frustrated by all of these Me Too products in behavioral health that were basically, they all show really small studies with good clinical outcomes and no evidence that in the wild people will actually use them. And there's such a low overall engagement rate in digital health. There has been, especially digital behavioral health. there are peer-reviewed studies that show high dropout in digital behavioral health, that show low long-term engagement. And so engagement really emerged as the differentiator. So I think I poked the bear a little bit by talking about that. Things do need to work. Obviously, clinical outcomes are really important, but that is very irrelevant if nobody will do the thing, if nobody will actually use it. So, for example, at Dario, we continue to believe that what matters to people is generally far more important than what's the matter with people. We focus on patient preference, like what I want, as a way of driving engagement. So we know that what people are interested in, for example, what they're curious about, what they're willing to try, what they really dislike, even the things that they hate. All those things are not only different, say, between me and you and me and other people, but they're often different within people. Like what I liked last month, I may not like this month or next month. So, when you look at all these solutions out there that say that they fingerprint, it often is a bit thin when you look under the hood. So they might match, say, for example, between cohorts. They may do persona-based matching. I think that's really good. We see a lot of that in first-generation digital health, first-generation digital behavioral health as well. They may even use machine learning approaches to kind of try to cluster some groups, but it's almost always pretty static. Like you get it and you're set. Or they might have some manual processes that will let you change those or adjust those. But there aren't really native capabilities within these solutions to dynamically adapt the user journey, like what I get, what I go through in this experience based on new insights. So it's like a set it and forget it, or a set it and manually adjust it kind of approach. So that's a problem, because the differences between me and me over time, especially with some variables, are even greater than the differences between me and you. So these very static user journeys, they create significant problems because they produce exits and churn. So if you're looking at user journeys, for example, on your platform, you're looking at maybe reducing the folks who leave, who exit the solution, who drop out, who churn out. Then you need to map out and understand and close off the various known exit nodes from those user journeys. And those exit nodes are very tightly connected to preference, to voice of the patient, to what I want, to what's important to me. And if you don't know, and they change over time. And if you don't know those things, then no matter how good your initial matching is, you lose. People drop out. So if you put it another way, let's say that you're plugging along, doing well, you're seeing a therapist that may be provided through your behavioral health solution, but you're just getting tired of that. I mean, who hasn't gotten tired of that? You get tired of that at times. Maybe you get frustrated. Maybe you don't want to continue doing that. There could be really good reasons for that. What happens? Generally, your choice is, okay, you pretty much drop out. Maybe you can change therapists, but it's a little awkward. Okay, you can do it. What if the process of moving between these different things were natural, were part of the social norm within the experience? It was just completely normal to move between these things based on what you want, because what you want is important to us. It's important to the outcome. And so you could move between cognitive behavioral approaches and acceptance and commitment. You could see a provider, you could do different things, coaching, not coaching, seamlessly move through these things in a way that makes sense for you, that you could really determine. And if the solution really dynamically adapts that way so that it's very seamless to your preferences, to your voice, then that's how we close those exit nodes from the journey, because it's relevant. It's relevant to you. And none of that is possible, getting back to your question, none of that's possible without the patient voice. If you don't know what's important to people, you can't do that. So patient voice is really the keystone to all of that.
Really helpful information. Can you talk about how the voice of the patient is involved in solving health equity and racial disparities in mental health care?
Yeah, so that's where voice of the patient, I think, really shines. In general, what we say is nothing about me without me. I have to be involved. So we really need diversity and representation, not just in providers, but in the designers of care. We need to ensure that we have a broad range of users, across demographics. We're paying attention to differences and the unique needs to deliver care that's matched to those needs. In one sense, digital health offers a very unique ability to help there, because with virtual care, some of the factors that affect type and quality of care may be obscured because you can't necessarily see what's happening. And since measurement-driven care is more common in virtual, so you might get more evidence-based care there. But there are other ways that it can really help with equity. Well, first of all, it's far less expensive than traditional care, so that increases access, right? If it's designed correctly, it can be delivered in a very backwards compatible way. So, for example, solutions that work really well with older generation phones, our solutions are backwards compatible to some of the oldest phones that are out there. So smartphones that you can buy for, $30 or even less. And since internet accessibility is itself a social determinant, some folks only access care when they're at the Wendy's or at the Walmart. So is the solution asynchronous? Are the user journeys designed to work in an asynchronous way? Can data exchange occur around, my preferences rather than the way you say it has to be at a certain, often very inconvenient time? And if your solution requires synchronous care, then you are really setting the terms of the engagement and not letting the patient do that. And that's not good. Same thing goes with multilingual support, for example, multilingual outcomes, culturally sensitive approaches to coaching within the applications, within the platforms. Do the platforms support and really enhance the ability to deliver culturally sensitive care? What we use is the respectful model, which I really love. That's an acronym, respectful. So it looks at religious and spiritual preferences, economic class and background, sexual identity, psychological maturity, which often plays a big role here, ethnic and racial identity, chronological and kind of developmental challenges and issues, trauma, and any threat to your well-being, family background, unique physical characteristics that you might have, location and language. I think I have that RESPECT. Right, tell me what that means to be FUL. So we build product off of that model, and then we train coaches off of that respectful model, which I think is really important. So look, I think if we listen to the voice of the patient, if we respond to the voice of the patient, if we honor the voice of the patient and patient preference, then we automatically solve some of the disparities, the ethnic and racial and gender and other disparities in care.
How can disruption of existing care approaches help elevate the patient voice in mental health care?
Yeah, Salome, you and I have talked about this topic various times over the years on many occasions, and how my view is generally that mental health care disruption needs to be retail disruption. Too much of healthcare innovation is a sort of creeping incrementalism that adds administrative burden without commensurate increase in value. It's part of the many reasons why healthcare markets are inefficient, why competition actually increases costs in healthcare, why many of the very hyped entities, and we saw this over the last year too, often fail. They fall, they get pushed up the ladder and then they have a long way to fall to the bottom. And all the other counterintuitive things in healthcare and all the perverse incentives that make the newer sort of starry-eyed entrants in the startup world of mental health and how they quickly become jaded and exhausted. And the reason why so many solutions end up failing. But if we take a truly retail approach to disruption and innovation, if we learn from direct to consumer kinds of solutions, then it ends up being about providing convenient, easy access to useful information, useful resources, tools, letting the voice of the patient, letting patient preference drive care. And that is going to take a very massive effort, since in general, systems in healthcare are very resistant to those kinds of change. They're very, very recalcitrant. So we need a more wholesale approach. It focuses on seamless delivery of care, focuses on personalization, including dynamic approaches, as I mentioned, to personalization, offering the full continuum of services in one place based on people's preferences and not based on some organizational or plan design. And approaches that really address access, that address social stigma, that address the various copays and financial barriers that exist. So so here's my, I think every year, if I do this every year, we're going to have one controversial idea. So here's my controversial idea for this year, for this year's Going Digital conference, and that's that network differentiation is even more hyped than AI. The idea that your network is amazing, that's going to drive outcomes. Sure, it can happen, right? We know that, but does it really happen that often? And the answer is no, it doesn't. When you might go to market that way, but when there's provider shortages and competing interests, everybody who starts out with the value prop for network differentiation ends up with a really broad network that's a mile wide and an inch deep. So that's another way of saying, I think, that network is a commodity, and I think that's a controversial idea. So what is it? If you say network is a commodity, what does that mean for disruption of care? And I think it means that digitally supported mental health solutions that can seamlessly integrate with a variety of provider networks, agnostically, that don't rely on a particular provider network for their value, that can deliver care across the continuum on other parts of the continuum besides provider visits, that are configurable based on what an employer, what a health plan, or what a health system needs. Those are the ones that are going to win the day. And in that category, there's almost nothing out there that's truly network agnostic, that's configurable to deliver across the continuum of care. So that's the disruption. That's the innovative idea. Network agnosticity in full continuum care, driven by the voice of the patient, driven by patient preference, that optimizes engagement, that optimizes outcomes. That's the novel idea. And that's where digital mental health solutions, especially telehealth, get stuck. And the big players are really stuck there. And so that's what's exciting to me. That's what's exciting to us at Dario.
Speaking of disruption, with COVID, we've seen a huge shift to telehealth, of course. And, I think many of us would agree that it's here to stay for mental health. What's next for virtual care in a post-pandemic world?
Yeah, that's the question, right? So I think it's important to start by tipping our hats to telehealth. I mean, it's been massive. We've seen a massive shift in the COVID times. I think many of your speakers predicted this last year. We've seen some pullback, but in general, it's remained very high, especially in behavioral health, which is in some ways very ideally suited to this kind of approach. I think that's a testament to the power of convenience, of simplicity. It's a good thing. It's a good thing. But I also think at the same time, we should be honest with ourselves. Telehealth hasn't really changed much in 30 years. The only difference is we use a little bit more. We use a lot more of it. Coverage has changed a little bit, and we have more providers doing it. But that's not innovation. It's basically the same thing that's been happening. And so if we're going to make this powerful enough to drive engagement, to drive improved outcomes, we're going to have to evolve it. And you're seeing a little bit of this here and there, but nothing game-changing. On the other hand, if we were to marry connected devices, both synchronous and asynchronous care, full continuum of care, integrate behavioral health into chronic condition care, and drive it with a real consumer-focused kind of approach, adaptive user experiences, that's new. That's new, and that's what's needed. So we're going to see more experiences that are multi-condition kinds of experiences, not just point solutions. I think the point solutions are becoming way too onerous for the employers and the health plans to deal with. We're going to see solutions that are provider agnostic. I think that's really important. If you're tied to your set of providers, that's going to be a problem. We're going to see solutions that don't have to do a lift to share data, but that share data natively out of the box. That's their data philosophy, not with some huge build out. Solutions that respond to voice of the patient, to user preferences, solutions that are very dynamically personalized. Convenience, I would say this, convenience and relevance are what really drove telehealth adoption like crazy over this last year. And convenience and relevance, that's what's going to drive virtual care as well. So people have evolving needs. And so pure behavioral health plays, no matter how good they are, pure behavioral health plays are going to be headed for obsolescence. They're going to be obsolete. We've seen managed behavioral health go that direction too, as their organizations have been forced to pivot and evolve, as the business models themselves have been threatened by value-based care. We say that we want to integrate, but then we end up hiring more pure behavioral health solutions, more point solutions. We force our customers to do the integrations and to solve the integration problem. And that's really absurd. It's basically entities that are trying to capture as much value as quickly as possible but it's not innovation. It's not the future. So, you ask about what's going to be coming next in a post-pandemic world. Multi-condition solutions, whole person solutions that sit on top of a personalization layer, modular kinds of approaches that are open, that are native, built for connectivity, open APIs. And then really when it comes to the philosophy of those, a data philosophy that is share first, not share if we have to, and share only what we need to. Those are the kinds of solutions that are going to win the day in the post-pandemic environment.
You've mentioned consumer focus a few times, and in the last year, we've seen so much direct-to-consumer solutions in behavioral health. Why do you think that's important?
Yeah, that's a great question. So direct-to-consumer solutions in healthcare. So when do they emerge? Direct-to-consumer solutions emerge in healthcare when covered care isn't cutting it. It isn't cutting it. And behavioral health is a prime example of a systemic failure to adequately deploy those resources. So people can't find it there. They're going to go pay for it and buy it if they can. And they can't always, and we talked about that. So, on the other hand, working directly with people who are paying for care, that can be an incredible laboratory to understand, what is it that's important to people, and to really design user experiences based on that. So at Dario, for example, we began in the direct-to-consumer space. We're still in the direct-to-consumer space. And we use a decade of experience in that area in user journey design to drive engagements, to drive outcomes in the B2B space, in the B2B2C space. And we do that based on what people care about, what matters to them. So the consumerization of healthcare, that's not going to stop. That's not going away. We know that that's going to continue. The question is this: who's going to make things so simple, so easy, so intuitive that it's actually easier to use the solution than it is to not use the solution? And I call that the singularity in digital health. That's the moment when everything else breaks and engagement is the path of least resistance. And it's just easier to do it than not to do it. It has so much value. It's so simple. It's so intuitive that it's the natural course. We don't have to force it. We don't have to push it. It flows like water. That's the singularity in digital health. And the direct-to-consumer experience is essential in reaching that critical moment, that singularity in user experience design. Complete virtual care is going to reach that. The question is, who's going to get there first?
Yes, a really good question. So now going back to Dario, congrats on all of the amazing success in the last year. I mean, I think like the market cap has gone up like 10x since you joined this year.
Yeah.
What's unique about your approach that you're taking at Dario in terms of patient voice, patient choice, everything we've been talking about here?
Yeah. Thank you so much for the compliment there. Yeah. Who would have thought that a year ago, when I left my former company, that we'd be able to walk in and 10x something within a year. So proud of the team for doing that. And we're just beginning to scratch the surface, since digital health has now still, even today, even in the COVID environment, less than a 1% total market penetration. So really, I mean, it's a little cliche to say this, but the sky really is the limit here, or, outer space is the limit. At Dario, we have several, I think, key differentiators that are leading us towards winning here. And those include, well, we just talked about direct-to-consumer DNA for all the reasons that we just talked about, that you just asked about. Dynamic rather than static approaches to personalization. So user journeys that adapt, native, they adapt, not just nudges, right? Nudges are super important. But nudges are communication, and communication alone isn't healthcare. The journey itself has to be personalized. So I would say the nudge and personalized nudges are kind of the bare minimum here. Another differentiator would be multi-condition, whole person care in a modular kind of design. So if healthcare is arrogant, then I'm going to say that digital healthcare is just narcissistic. Solutions out there will silo their data. They focus on proprietary data. They expect to be setting the digital strategy for their customers, which is, I think it's just ridiculously self-centered, and it's not going to succeed. And by contrast, Dario is modular, configurable, open by design, open by philosophy, and built to cover the most common chronic conditions in a whole person way. So our customers can set the digital strategy, and then we plug in where they need help rather than setting it for them. Another differentiator for Dario is engagement oriented, structured to provide very transparent metrics around engagement. It just turns out a lot of the solutions in the space are a little obscure in that area. We're device and care model agnostic, so we can kind of fit into the complex ecosystems rather than forcing them to change to get value. And then patient driven, voice of patient driven. So adapting solutions based on what people will actually do. And so those are some of the differentiators. So, yes, of course, we do have academic outcome data. It's very important. We have, for example, recently a UNC study that showed big reductions in anxiety and depression in users of our platform. But I think even more importantly, we have a path to configurable integration into complex ecosystems that ensures that our customers can solve their problems instead of asking them to solve ours. The voice of the patient is really key there to ensuring that our customers get the outcomes they want without workflow disruptions. I want to say this, Salme, on another note, I want to say this too. You mentioned to me that you're donating the profits from this conference to Beam to ensure access to underserved populations, and that's amazing. And one of the core values for Beam, as I understand it, is dismantling the systems that dehumanize care for Black Americans. Dehumanize, think about it, dehumanize. When do things get dehumanized? That happens when the people who are served are objects rather than people. When people's voices aren't heard, when we don't have the voice of the patient, when they aren't responded to. So voice is key there too. And voice of the patient is key to the future of mental health care. And voice of the patient is key to solving the health inequities. And I'm proud to be friends with someone like you who's advocating for exactly that.
Amazing. Thank you so much, Dr. Manejwala. The voice of the patient really is the future of improving access to mental health care. Super insightful as always. Thank you so much for sharing your time and expertise with us.
Thank you, Salme.